In Jesus' name we pray. Amen.
Amen.
All right.
All right.
You got the
Good.
question. Hmm.
I do. Yep. All right.
Okay.
Good day, everybody. It's Alexia, your Coco Doula, and I'm so excited to be here with you today. Got a beautiful expert, if you will, in the maternal health space. Sister Malika, just give a quick intro, if you would, please.
Hi, my name is Meleika Young. I am a labor and delivery nurse. I have been a labor and delivery nurse for the past, can you believe this? Like 24 years. Okay.
I love it.
Anyway, I am the team leader for the Doulas For His Kingdom's ministry, and I'm so excited to be able to bring to you today a video. We are going to do our best to, just make it happen. Sit back, laugh, enjoy, just get the knowledge that you can get from this. And I'm sure we'll probably have a part two. But anyway, take what you can take from this and let's go. All
That's
right.
right. That's right. Well, let's first just kind of start off, if you would, just giving us some insight into what the experience is like, especially from yours. So I'm a doula. We're non-clinical. For those of you who may not know, we are emotional support resources for the mom. I always like to tell people we handle from the waist up. We want to make sure mom is good, mind is good, and we want to be a support resource there. And we know the number one or 90% plus birthing space for our expecting people is in the hospital or maybe even a birthing center. So you being able to share your feedback is and just your insight and wisdom is really special. And so just kind of give us, and I'm going to pull up a quick little screen here as you talk through, but just give us some of your insight, if you could, please, about the birthing experience.
Okay, so let's start with this. What does the birth experience look like? Okay, so it's really, really important to start from the top. The best way for the doula and the medical staff to work together is for everyone to work towards the common goal, which is the best interest of the mom, is a healthy baby, a healthy family, a healthy delivery. That's what we want. So the medical team usually has a relationship with each others. The doulas, you're coming in, you don't have a relationship with the medical team, nor does your mom that you're serving. But because you're coming in together, you two are a team already. And when you come into that space, you want to come in, cheery. You just want to come in friendly, and you just want to come in being open to just become part of the team. You're now becoming part of the team because you're coming into that space. So a couple things that I'd love for you to know. Number one, try to let's pull up the labor form. Let's pull up the labor sheet. I just want to kind of go over this with you, with you. It's like kind of best practices. Perfect. Yes, that's it right there. Okay, number one, let's look at this. Be warm and welcoming to the healthcare team. And guess what? The healthcare team should be warm and welcoming to you. The same way that you want to be treated is the way that they should be treating you. Number two, introduce yourself to the nurse, introduce yourself to the staff. Sometimes you just got to get out your comfort zone. Remember, you're coming into their space. So therefore, you go ahead and just, introduce yourself so that way you can work out the best plan as a team, and be yourself. Work within your scope. Ask and see, what is it that you can do. Is it anything that you can do? Like, what are the protocols, what are policies? Just ask them, like, what are the do's and the don'ts, just so you know up front. Like, for instance, maybe you don't want to be in a certain space, so you may ask them, hey, what space, where am I okay to be? You can ask them, hey, is it okay if I bring certain things in? Sometimes doulas bring in candles, sometimes doulas bring in different props. Just ask, is it okay that I have this, especially like the candles? Number three, always, just ask the nurses about position changes. Like, is it okay? Nurses love, and the medical staff, they love for you to be a part of the team. They love for you to do these position changes, but you just want to make sure whatever position changes that, oops, sorry, this is going on. Whatever position changes that you want to do, you just want to make sure that we can still see the baby. So for instance, if you're going to have the mom standing up, we got to make sure the baby's still on the monitor. Sometimes, we have these wireless monitors that you can walk, the moms can walk, and we can still see the baby's heart rate. But a lot of times we don't. So the moms are connected to a machine. So whatever you do, whatever position changes you make, let's just make sure the baby is still on the monitor. And always, if the nurses or if the staff has an issue with a certain position, just kind of follow that, because sometimes moms have something called variable decelerations, and that's where the baby's heart rate goes down. Accelerations, the baby's heart rate goes up. We don't have to get any we don't really have to go medical with that, but just know whatever positions we do, we're going to do it within the best interest of the mom. All right. Number 4, make sure that you continue to provide emotional and physical support to that mom. Let's monitor the room temperatures. You may not understand about the strips and watching the strips, but mom might start looking at it and have some questions. So if that's the case, when the nurses come in, just support mom with her questions. So if she's asking, hey, guess what? Then you get involved as well. You get that same information so that you can learn, because knowledge is power for you. And then that way, when the nurses or somebody's out the room, you kind of know what you're looking at. So you can kind of see, like, if the baby is off the monitor. You may not, and you don't have to know about what the heart rate is. You don't have to know all that. But the biggest thing is you just want to make sure the baby is still on the monitor. So you're keeping an eye on that. And then just, of course, just making a mom just feel overall, just making her feel like you're supportive and that you're there for her. Let's see, number 5, dirty linens. If you have some dirty lemons, it is totally within your scope. If you need to change the mom's gown, if you need to do anything like that, change a pillowcase for the mom, change a sheet for the mom, it's totally within your scope of practice to do that. And you can go ahead and toss the dirty linen in there. We usually do have like blue linen cards. So you could just toss it in there, or you could just ask the staff, hey, where is the best place for me to put the dirty linens, if you're unsure. And then also we have like red trash cans that'll be in the hospital. It's white trash cans and red trash cans. Red trash cans will be for like bloody products and stuff like that. You don't have to worry about that. But the white trash cans, you can throw their food in there. You can throw their old cups. You can throw their their cups of ice when they're finished. You can throw that stuff in there. So be comfortable with that. And one of the last things is just support their natural techniques. That's one of the nicest things. You can help them with their breathing. It's just certain things that you can do in those situations. You can rub their back, and just feel free to support them in their questions. And just remember, I think this is one of the biggest things. I probably hit on this already. Medical staff, or in particularly nurses, I'll say, don't really like it if you're standing right in front of the monitors, because that's kind of like our space, because we have to be legally responsible for seeing the monitors, and legally responsible for checking the IVs, and legally responsible for watching the medications. And if you're in a certain area, it won't be beneficial for us. So therefore, it's much better if you stand at a certain space. And if you do that, you won't be in the way, and you will just be totally part of the team. And last of all, talk to your nurses. Again, be friendly, ask the questions, and feel comfortable. And this is a whole team effort. Trust me when I tell you. I personally appreciate doulas. So just so you know, some nurses some staff may act a little funny, but if you kind of follow those tips and be friendly, you'll be fine. All
Thank
right.
you. I love that. I love that. And I love how you incorporate it too. Like, you just got to be prepared. It's like anything else when we show up in each other's homes, right? We want to understand what's the lay of the land. What's the phrase they say, when in Rome, if you will. And so we are there to be support. We want to make sure that we set the best stage. We're there to support the mom. And we want to make sure that there's a healthy outcome for mom and baby. And so it's important that we are able to build these relationships so that sees through. So thank you very much for that. And especially sharing the experience. I think it just goes a really long way. Another question that I have for you is, so one of the things, and it's kind of a 2-part question, or a couple-part question, I should say. But when it comes to the medical staff, right? Like, how do they know, for the, particularly thinking for the mom, how do they know me as the mom? How do they see me? How are they able to learn about me in that space?
Oh, that's a great question. So first thing is prenatal care. If mom is getting prenatal care, they are going to know you. So it's kind of 2 different folds. Some moms get private prenatal care. So they go to their obstetrician, and they have a set of doctors that they see that rotate, and they have a practice that they go to. So they may see Dr. A, Dr. B, and Dr. C, and they rotate with their appointments because they don't know when Dr. A, B, or C will be on call when it's time for me as the mom to deliver. So therefore, I need to see everybody in a practice so I can be familiar with who they are. All right. But then you also have a clinic. Some moms go to a clinic. And if you go to a clinic, then at the clinic, it can be multiple attendings that could be at the clinic, and it'll be a lot of residents. So you'll see a lot of residents in the clinic. You also see midwives. You can also see nurse practitioners. So you'll see a slew of different people. And then when you come into a hospital setting, it depends on which hospital setting you come into. If you're coming to a place like, I'll give an example, Chester County, which is in Pennsylvania, that is a hospital that only has attendings. It doesn't have residents. So that means like the attending, the obstetrician that you would have saw in the clinic, those are exactly who you're going to see when you come into the hospital. But when you're in a clinic setting and you come to a place like Pennsylvania or Temple, you're going to see residents as well as attendings. The residents are going to be the ones that you're going to see. They're going to have their hand in the pot. They're going to be doing everything. But when it's time to deliver, that attending is going to come in because that attending, he or she oversees that delivery. So I just want to make sure it's clear and that you can understand that. Now, you will be able to see it attending if it's something going on that is above the scope of the resident, above the scope of the midwife. You will see an attending pop in if it's an issue. But for the most part, if you're having residents, you're going to see them. You're going to see that attending in the end. But again, if you are in a private hospital and it's just the attendings coming in, you're going to see the attending and you're going to see the nurses, because the nurses are the ones that stay by your bedside. Those are the ones that you're going to see, and they go on shift 7A to 7P, 7P to 7A. You see them when they change shifts. So I want you to, Lexi, just pull up that initial report sheet. I just want to show you something.
Got it.
Okay, so this is one of my personal initial report sheets that I use. So me as a nurse, you know, as I started traveling, I started realizing that I needed to acquiesce to the place that I'm at. So I had to learn how they do their reports and what'll work for them, because each institution, they do something different. Now, don't get me wrong. Everything is the same as far as, hey, this is the mom. How many times has she been pregnant? What is her age? What is her medical history? All those things are alike across the board, but it's just certain things, some information that may be more pertinent in some institutions than in other institutions. So one of the things that I like to look at and how the medical staff, how they know you, is they have a computer system. Some of the computer systems they use, a majority of them use something called Epic. And in Epic, it's across the board. So we get to see your prenatal care. We get to see your visits, what happened at the visits. It's all talked about, all of your labs, all of your information. If the mom you're dealing with is on drugs, if she's doing something, it's going to show. We want to see it. Now, when the mom, and as a doula, when you come into the hospital with the mom may not know this, but we already know a lot. We know more than the mom thinks that we know, because it's already there, down to whatever she did at that clinic. And when I go as a nurse or as the residents, when you're coming into the hospital, when we go in to look at the chart, we pull all those intricate details up. So we have a full picture of you. And then we do something called a huddle, which means that at the beginning of the shift, the nurses, the medical staff, like the nurses, the doctors, the techs, because you'll have techs at the hospital as well. And let me just back up and tell you that when you come into the hospital scene, you have something called the attending. You have the residents. You will have a midwife, a nurse practitioner. It just depends, because the midwife can deliver your babies. And you'll also have something called techs. The techs are who go into the OR if you have to have a C-section. They are the one that helps that doctor in the OR. They assist in the OR. So the nurses circulate. What that means is we're circulating around in the OR. We are not sterile, because you have to have a sterile environment for a C-section. But the doctors and the techs, they're sterile, and they're the ones that are, making the incisions. They're doing the cut. They're doing all those important medical things to have a healthy delivery with a C-section. So anyway, I just wanted to back up to let everybody know
No, I
that.
love that. Thank you for that.
Yeah, and so with report sheets, what I'm showing you on this report sheet, is something that I use, and this is something that I would go ahead and I would report to the next nurse coming in. So my expectation is the nurse that I'm getting report from, she's telling me some of this information, whatever information on my sheet that she didn't give me, I'm going to go into the chart and I'm going to fill out for myself, because as a nurse, I want to know everything about my patient, so I don't want to have any surprises. And the other thing we do is when we come on shift, we look at the patient's tracings. We look at the fetal heart rates. We look at the computer. And most places, well, yeah, all places now, they have what we call central fetal monitors. So even though you see the fetal monitor in the patient's room, we also have it outside at the nurse's station. And when I sit at the computer, I can pull it up and I can see the tracing right in my face. And I have to document on the tracing based on the hospital protocol. So I am constantly aware of what's going on with that baby. And you would be very, very surprised to know, but we actually chart. And when I mean chart, we're typing in, we're looking at that monitor strip and we're charting every 15 minutes if they're on certain medications. Can you imagine that? You got to chart every 15 minutes for a 12-hour shift if they're
That's
on
a lot.
dosing, or maybe every half hour if they're on something else like side attack. It is a lot, but it's intense. And these are the things that you don't know, the backdoor stuff that you don't know. So I know that's just a little snippet, but it's much more. But at least, this is something so you can get some type of understanding of what the nurses and what the staff is talking about and what they do know.
Yeah.
Oh, and last thing, remember, any information that you get from your patient as she exposes and tells you, make sure that it has to be okay when you talk about any of this if she has a family member in the room, because some of this stuff, this
Mm.
information, the patient's family, they don't even know. Like I've
I
had
remember
patients.
that.
Yes, I have
Yep.
patients who have had HIV and their partner didn't even know. We had to cover
Mhm.
up the medications. I've had patients who have herpes and their partners, their mothers, their family, they don't know. So we have to be very, very quiet about what we do. And if the family member asks questions, we don't answer them. We'll just
Mhm.
flip around that, because they're not privy to that. So if you notice, you may find that if you come in with your patient, depending on when you come in with her, she may expose to this staff, like, listen, such and such doesn't know this. Please do not say it. And you make
Mm.
sure as the doula that you are mindful to not say it either.
That's
Okay.
perfect. Thank you for that. And for those of you who are tuning in, that's why it's so important to be familiar with practices like HIPAA.
Yes.
That is the healthcare information
Yes.
portability. It's the healthcare. Why do
Got
I
it.
always get caught? Health Insurance Portability and Accountability Act.
You got it. You got it.
So that's why it's important to be familiar with that. Okay, that is some good stuff. You are really schooling us here. Thank you so much. This is helpful. All right, so I got a couple more questions for you.
Sure.
Just wanted you to touch on too, and maybe as you share about this piece of it, you can answer a couple other questions. But I want to
Sure.
talk about the stages of labor. And
Okay.
within that, if you could also share maybe a little about what a doula can do to help in that process. Maybe talk a little bit about when the pivot has to happen, because that's another big thing that we've been lifting up is you got to know sometimes you got to prepare for the pivot. So that
Okay.
means if you wanted to go unmedicated, but now you got to get an epidural. If you want to do vaginal, but maybe now there's a C-section. So if you could, in talking about the stages of labor, just hit on a few of those pieces too, if that's okay.
Sure, I will. I'm gonna back up for a quick second before I say the
Yes.
stage of labor, and let me tell you about a quick induction. Because before
Yes.
I
Yes.
say labor, I want you to know about what an induction is. And as a doula, you will probably come in and you will have to be your patient, your mom will probably be induced. So this is going to be before labor. So if she has to come in for an induction, do you know why? One of the reasons why we do inductions, and inductions, it just prompts the uterus to contract during pregnancy, before the actual labor process begins. And we do that with the use of medications, or we do that with the use of mechanical devices or other methods. So medications, and we'll get into medications later, but it can be like a Pitocin, a Cytotec, or it can be a mechanical induction, which can be something called a Foley balloon. And that's crazy because you're going to actually take a Foley catheter. And if you know what a Foley catheter is, that's the area where you kind of urinate, you pee. for lack of better words, the
Yes.
catheter you stick in your urethra, we take that same catheter, but it's bigger. It's much bigger. And we
Woo.
put it in your uterus. We stick it through the vagina, into your cervix, up in the cervix, and then we take water and we blow into the balloon. We inject water into the balloon. So that balloon now, so if this is your cervix, if this is the cervix that's closed, like a little hole is closed, well, the balloon goes in and it just blows
Oh,
and it holds it open. So the balloon will put in probably about 60 cc's of water in there to hold that balloon open. And the reason why we do that is because it'll mechanically make your cervix feel like it dilated. So it'll kind of sit. It'll be like a fake 4 or 5 centimeters by the time it comes out. So literally it goes in. We'll add medication to that. So you'll get something like a Pitocin to go in to help you contract. And again, I'll go into that, but it'll help you to have these contractions. And the actual Foley bulb, the device will fall out on its own. It'll come out on its own. But the reason that you won't know it came out on its own, the doctors or the nurses will pull on it occasionally, like every 2 hours will come and pull on it. And once they pull on it, and if it actually pulls out, then you are definitely going to be about 4 to 5 centimeters. But
and what would make, and I know you're talking about inductions, what would be the reason for that? Because I know one of the things that we are also, moms and birthing people, and especially us, we want to let nature take its course, if you will, right? God gave us our bodies and it does what it does. However, we do know again that sometimes there's a pivot. So when would an induction possibly, we know there's always exceptions and things like that, but what's the most common reason for an induction?
Okay, one of the most common reasons for induction is the mom is already 41 to 42 weeks pregnant and is post-term. That's what we call it. When they're over 41 and preferably over 42 weeks, they're post-term. Sometimes babies just don't want to come out. And so we go ahead and induce them because it's more beneficial to come out at that time than to wait. You don't want to have a stillborn baby. So sometimes the babies are just too big and they don't want to come out. Sometimes they're just not in the right position. They just don't know it's time to come. So we have to help them out. Or sometimes a mom water breaks before labor begins. So actual labor, the actual beginning of the labor part, when you start dilating 1 to 2, you're in like this new latent phase, 0 to 3 centimeters. When you start opening up on your own naturally, that's one thing. But when you don't do that and your water breaks, because your water can actually break before labor begins, we got to induce you because we don't want you to get sick. We don't want you to get a fever and something called chorioamnitis. And that is an infection in your water, in the amnio fluid. We don't want you to get that. Okay.
Okay.
So that's
Perfect.
something.
Thank you for that.
And it's a plethora of other medical
Right.
reasons,
Right.
that So yeah, so that's what we do. Now, to get into the stages of labor, we'll go ahead and pull that up. All
All
right.
right. We are moving right along. Thank you.
You're welcome.
All right.
Okay. So the stages of labor. Let's see if we can we bring it up any bigger? If we can't, it's okay. I have it.
They may be able to zoom in as they're watching, just to see a little clear.
It's all right. So, okay, because later on, if anybody wants any of these forms, we can kind of email it to you. All right, let's just talk in general about stages of labor, and we're going to be quick with it. So, there are actually 4 stages of labor, okay? So, stage 1, that is when the cervix begins to dilate, okay? And it ends with complete dilation. So, stage 1 can be from fingertip to 10 centimeters. You need to be 10 centimeters to dilate to actually have a baby. And in this stage, which we call the first stage of labor, you have something called phases of labor. So phases of labor will be something called the latent phase. That's 0 to 3 centimeters. Then you have the active phase, which is 4 to 7 centimeters. And then you have the transition phase, which is 8 to 10 centimeters. But I am here to tell you that we call active now, we call that at 6 centimeters. 6 centimeters, you are in active labor. You will notice that at the hospital, they'll say you 6 centimeters, you are in active labor. And what that's going to mean is if you are not progressing from 6 centimeters, if you're not moving along, something is going wrong, because that is a better indicator than a 4 centimeter. Because like I told you, if you have an induction and you put that cervical, that Foley balloon in there and it comes out, you're 4 to 5 centimeters, but you're like a fake 4 to 5 centimeters. So imagine you come out with that and we're like, yeah, you were in active labor. You're really not. And we start the clock at 6 centimeters. And when I say start the clock, we start the clock to say, hey, how are you actually progressing? That's a better indicator of starting the clock at 6 centimeters than to say at 4 centimeters or 5 centimeters. Okay. Stage two, that is going to be from the time your cervix is completely dilated, so that mom is 10 centimeters, to the time she delivers that baby. That's stage 2 of labor. Okay. And then you have stage 3. Stage 3 begins from the time the baby comes out to the time the placenta is delivered. And I hope you all understand that the baby was attached to the placenta, which gave the baby the nutrients from the mom. And that is how the mom and baby exchange blood and nutrients. In that placenta is highly important, and it's so many things that can happen with that placenta. So that's why that's a stage, because if that placenta does not come out, it's some complications that can occur, and we may have to go in and manually take that out, or the mom can bleed. She can bleed out, and we don't want that because it's still attached to the mom. So we needed to detach from the mom's uterus, and we already detach it from the baby. When the baby delivers, we cut the cord, so the placenta is still attached to the mom. Now it just takes time for us to get that placenta to detach from the mom's uterus. So all these stages are very important, and it poses a high risk to the mom. Some things we just kind of take for granted, but it's some things behind the scenes that we just don't know. And moms have died, during this time. They've had to run to the OR. They've had to manually get this placenta come out, or it has just attached. And literally, moms had to get their whole uterus taken out because the placenta wouldn't detach. So that's a whole nother. Okay. And then we have the 4th stage of labor. And the 4th stage.
And can we just, because that's, that's a lot, in that 3rd stage. And we want to make sure as birth workers in this space, we understand why from this stage, especially, you have to be strong in your emotional support here, right? Yes. So that we can make sure. And so just understanding what those statistics have shown and disparities, this is why it's so important that we're present, that we're helpful. We know there are certain things we can't avoid. But as much as possible, we want to make sure that we're prepared to serve mom through any of these stages that Sister Meleika is talking about, because as you can hear, right, that is extremely traumatic to go through those things. And so we need to make sure that we're armed with the information so we can support best. So I just wanted to plug that really quick there too. Not to scare, just to inform so we're prepared.
Be on high alert. And what you can do during that time is, hey, you can give mom the ice. You could put the cold rags over on her head. You can hold her hand. You can talk to her. And as doulas, we have prayer. So as doulas during this time, this is your time where you're praying. Mom don't have to know you're praying, but you're praying. You're right there. You're like, Lord, you're dispatching them angels in the room just to get her through. So some moms, the placenta comes out like this, but some moms, they don't. And we have a timeline for that as well, for how long we'll wait for that placenta to come out. And I want to say that it may be just about an hour, if not less, but it's definitely around that time. And then you have the 4th stage of labor, and that is when the delivery of the placenta, and then it continues 4 hours after birth. Now, I just want you to know, the time after the mom delivers is one of the most crucial times, because we are going to give them Pitocin again. And again, we'll get into Pitocin, but we're going to give them Pitocin because that's going to help their uterus contract. This is the time where the moms can bleed. If they've had an induction and they've been like having a 3-day induction, because these inductions can take 3 days, labors can come and you can go super quick. It just depends on the mom. Every situation is going to be different. But once you deliver, you have a risk for something called postpartum hemorrhage. And if you have a postpartum hemorrhage, all the bells and whistles are going out. We are trying to stop that bleeding as best as we can. And it's so many things that go along with that. And again, moms have died in that phase. So we're doing things like possibly taking a mom to the OR, giving her something, what we call is a Backery. It's like a mechanical machine, a mechanical balloon that goes in the uterus, that just kind of presses against the uterus to hold pressure. Just like if you have a cut and it doesn't bleed and that won't stop bleeding, we have to hold pressure. We have a device, a balloon that'll hold pressure on the uterus.
And I appreciate you bringing up about the postpartum hemorrhage, because that excessive bleeding. And so what are the sorts of things that as a doula, we, a question like as we're preparing for birth? So we don't like to say, one of our good friend midwife, Michelle, says, let's stray away from birthing plans per se, and maybe zone in more on like birthing goals. And so when we're asking questions to prepare, isn't there like a cart or some sort of medications and things that are usually already prepared for that postpartum hemorrhage? In case, God forbid, but in case, could you talk a little bit about like how you all prepare just in case?
Absolutely. We anticipate the unimaginable always.
Yeah.
For every delivery, we have a postpartum hemorrhage kit available. And it goes a little deep because it really depends on the situations. Sometimes you can't even predict that it's going to happen. So that's why you want to have your postpartum hemorrhage kit available and ready. So if a mom is in labor for hours, you may expect that, guess what? That uterus may be tired. When it's time, once she delivers, it just may not firm back up. It may just stay in a state of just like, I'm tired. And if it stays tired, you're going to bleed. And we got to use medications. We use different things. We use like Methergin. We use Hemabate. Medications you may not be familiar with, but we use all these medications in order and site attack. We do these and we'll do them simultaneously and we move fast. So as a doula, when you see these things that are occurring, you're just supporting mom, because now we move into an emergency mode, and in emergency mode, we really can't talk.
Right.
And we prepare mom ahead of time. When the doctors are getting consents, when she comes in, they talk to you about what can happen in the case if we have to have an emergency C-section or different things that go on. We talk to the mom about that ahead of time. And I always tell my patients, I'll say this: if don't put your umbrella up if it's not raining, and if you see me put my umbrella up, that's when you put yours up. But if you don't see me, don't do it. You don't do it. That's what I always say. And I develop a rapport with them and I talk to them. So you as doulas, don't feel any type of way with encouraging your mom to ask questions and to talk. And guess what? You as doulas, write notes for yourself so that way you know. And then sometimes moms may forget some things, so you may be able to bring it right back to mom. Like, oh, remember this is what they said, or something of that nature. And clarify everything with the nurses and the doctors. It's okay. So yeah.
Oh,
So
I love that.
we prepare ahead of time, always, for everything.
Awesome. Yeah. Okay. I have one final question, if you will. And this has been great. And you are right when you said in the beginning that there will definitely be a part 2 to this. Be able to continue on, but this is so helpful for this space. Talk a little bit about like you hit on it a little bit, but the comfort measures. So now talking to our doulas in this space, what are some of the comfort measures that the doulas can provide or that you've seen doulas provide? And then 2, for the mom, like when it's time to push, right? When we've gotten to that point, how can the doula really support that process? So what's the comfort measures leading up? And then what are some best practices you've seen in that space?
Sure. Lexi, I don't think we talked about this, but I don't know if we had that little the little picture where it has like all the positions.
I think let me see.
And it says it's on that same sheet. It's all the way at the bottom. It's the last one.
Okay. Gotcha. I got it. I will go ahead. Thank you for that. Let me go ahead and bring that up. Yeah, this is good. It's good to have some examples too visibly that we can share. So why don't you go ahead and start sharing some information about it, and I will pull that right on up.
Sure. Okay. So some of the comfort measures that you can do for your mom is, again, number one, giving them ice. Making sure they have fluids. That's a given. That's natural. You can rub their back. You can. You just kind of are encouraging them. That's just normal things that we do. But then we have actual props that you can use, and Lexi's going to bring that up when she can, and that'll be something called like a birthing ball and like a peanut ball. And guess what? You can actually have these things yourself that you bring in. Oh, and how about this? Sometimes those nice scented candles that's in the room, it brings an ambiance in the room, or music. You can talk to your mom about what do they like, what keeps them nice and calm. There we go. Here we go right here. Okay, so on this sheet right here, you get to see so a birthing stool. You can see the mom. Let's see if you can see. She's kind of sitting. It's at the top. It looks like something that's like a scarf, but it's like this third thing over from the scarf. The scarf is called reboza, and the reboza, if you look right under the scarf, if you go right under the scarf, Lexi, are you able to point your yeah, right there? The mom is actually taking that scarf and she's like pulling it up over the mom's, like under the belly for support. Like that's one thing that you can do, but in the hospital it's not always feasible. But if you have a mom that's just kind of that's able to walk around, you can just kind of gently kind of pull that under, put that around her just for support for her, because sometimes that belly is so heavy that just having that is comforting. And then you have, so these are positions, and you have the peanut ball. The peanut ball, it just looks like a big peanut. It's all the way at the bottom. Yeah, you got it. The peanut ball, they help mom with position changes. They help mom so it expands the pelvis. I call the peanut balls the magic balls, because those peanut balls, they get moms to deliver pretty quickly. And I don't mean quick like in an hour, but for the most
Yeah.
part, those really they improve, and they help quicken that labor. And that is because it literally keeps those legs open, and it keeps the pelvis open, so it helps the baby to come on down. And then you have like the birthing balls. Those birthing balls, that you can see, those are the big balls. You see mom sitting on a ball, you see mom laying against the ball. Those positions, those are comfort things, comfort measures that you can do for moms. That's exactly, and it's so beneficial for the moms, because it gets her moving and gets the baby moving. And then you have the bar, that birth bar. Some hospitals will provide it for you. As a matter of fact, all hospitals have it. We don't always use that birth bar, but some moms like the birth bar. And that bar is like right on the bed. And sometimes moms can squat with the birth ball. You see the lady, she's squatting. You have moms, she's kind of laying back with the birth ball with her legs up. So all these positions will help. I mean, just imagine, really the biggest thing that I can attribute birth to, and I'm sure for any of you who have had babies, I used to say that it felt like when I was having a contraction, it felt like I was so constipated. And when I had to go to the bathroom, it just was like amazing when it finally came out. But I had to like, I had to move around, and I'm just being great.
Listen,
I had to move around on the toilet. Sometimes I just had to do what I had to do,
yep.
and that is the same for moms in labor. So you're supporting that.
And I thank you for that. I just want to go up to the rebozo real quick too. That is a technique, that scarf that Sister Meleika was talking about, if you will, that material, that is also indigenous to the Latinx or Mexican culture. And so that's another piece. Now, here's the thing. We never want to misappropriate any of these practices, right? Especially the cultural indigenous practices that are native to the African diaspora, and the likes thereof, right? And there are some things that have been supportive and helpful. And so it's also good to inform yourself before you jump into any of these practices, just to make sure that you feel strong in that positioning too, and that you're knowledgeable about it as much as you can. So I just want to throw that in there. I am so excited about this experience from as we start to kind of close out this particular session of hospital best practices and how us as doulas can serve and build relationship in this space. Any final feedback, words, thoughts, encouragement even?
For me, yes,
Yes.
I'll give you some.
Yep.
Okay.
Give it.
What I will say is trust yourself. I will say, first of all, trust God first. Okay. Have confidence in you. Prepare. No matter what we do, we got to prepare. When you know that you're going to go into those deliveries, you know what? Get yourself a bag. Have some things ready already. Be the best you that you can be. And be encouraged because you will learn things along the way. So take notes with your deliveries, and that way your next delivery will be better than your last delivery. And each delivery will be different. But at least now you'll start learning. You'll gain knowledge, and knowledge is power. So that's what I'll say. That's my encouragement.
Oh, I love it. So just for us as we are navigating it, and this was really helpful to me too, because sometimes you can get anxious because you want to do well, you want to do those things. And that's why we're so thankful again, even to our ministry, Enon, for being on the forefront of this space from a faith-based organization perspective and starting this doula ministry. And our goal is to be able to continue to support in this space. Maternal Outcomes Matter. It's all about the mom. And so for us as doulas, being able to build these relationships, get you some labor and delivery nurses in your crew, some OBGYN, some midwives, some social workers, like all the different spaces that we will need to serve moms in. There's a lot of intersectionality, and we know that there's influence from these social determinants of health. And so as much as we can come together in this space, we can. I am so thankful to you, Sister Meleika. Thank you for your leadership. Thank you for your tutelage, and just your obedience to this call too. More to come, peeps. Again, as she said, enjoy, take notes, and continue to be informed. We appreciate it so much. Be blessed.
Yes. Be blessed.